We are going live in 3, 2, 1. We are live now.
Good afternoon, everybody. Myself, Dr. Vishal Dave, Medical Advisor in Intas Pharmaceuticals. On behalf of Intas Pharmaceuticals, I welcome you all for this Indian Fertility Society Jharkhand chapter webinar on the topic endoscopy in infertility, optimizing the outcome. It is my privilege to welcome the Master of Ceremony, Dr. Preeti Sahu. Dr. Preeti Sahu is consultant gynecologist and infertility specialist at Anjuman Islamia Hospital, Ranchi, and at KC Roy Hospital, Ranchi. She was junior consultant at Shanti Mukund Hospital, Delhi. She did her MBBS from HIMS Jolly Grant, Dehradun, DGO from BRD Medical College, Gorakhpur, and DNB from Hillview Hospital Research Center, Ranchi. She had also done 3 years senior residency at Bhagwan Mahavir Hospital, Delhi. She also done fellowship in minimal access surgery at World Laparoscopy Hospital, Gurgaon. Now over to Dr. Preeti Sahu.
Thank you very much, Dr. Vishal, for such nice introduction. Good evening, everyone. I welcome you all in this webinar conducted by IFS Jharkhand chapter in association with SIG Endoscopy. I will like to welcome our patrons, Dr. Karuna Jha Madam, Dr. Sunita Jha Madam, Secretary, Dr. Rupashri Purushottam, our guest speaker for today, Dr. Desh Deepak, uh, Chairperson, Dr. Vinod Agrawal sir, panelist, moderator, Dr. Mansi Jain, and all the panelists, Dr. Aarti, Dr. Alankrita, Dr. Anjana, Dr. Nivedita, Dr. Soumya, and Dr. Sakshi. Today, we have a very important topic for discussion, which is endoscopy in infertility. We all deal with infertility patients in our day-to-day practice, be it a general gynecologist obstetrician or IVF specialist. Sometimes we are able to diagnose the causes by routine ultrasound and blood investigations, but many times we are not able to diagnose the causes, like uterine synechia or small polyps or many other causes. So here comes the role of endoscopy, like hystero and laparoscopy. By doing endoscopy in infertility patients, not only we can diagnose the causes, but we can also treat them in the same sitting. So nowadays, endoscopy has become very relevant and important in patients of infertility. So now I will like to invite Dr. Rupashri Purushottam. Madam, can I have the CV of Dr. Rupashri? She is the secretary, Jharkhand chapter IFS, and she is also a clinical director, Avita Test to Baby Center and Aesthetic Gynecology Clinic, Ranchi. She is founder, member, and treasurer IFS Jharkhand 2018 to 23, joint secretary ROX 19 to 21, organizing member of East Zone Yuva Foxy 2022, invited faculty in regional and national conference, and she has been awarded as recipient of IFS Achievers Award, listed as top IVF doctors by DNA Web, MSc Signature Award in 23 as Best State of Art IVF Center of Jharkhand, Jharkhand Health Excellence Award, Pride of Jharkhand in 22, and Nari Samman Award in 2019. Her special area of interest is high risk pregnancy, infertility, and aesthetic gynecology. So now I'll request Dr. Rupashri ma'am to say few words about this webinar.
Good evening and warm welcome to all the faculty members and delegates. Thank you so much, Preeti, for introducing me nicely. And really, it's giving me immense pleasure as a chapter secretary, Jharkhand, to be part of this program with conceptualization of collaboration with a special interest group, which is a great visionary of IFS President Dr. Pankaj Talwar sir and Shweta Mittal ma'am, where we can focus on a special subject and get insights from the expert. So it's really overwhelming that Jharkhand chapter got the opportunity to club with SIG endoscopy for knowledge sharing. And thank you so much, Dr. Mansi, for reaching us. And today we are blessed to have with us a distinguished speaker, Dr. Desh Deepak sir, who is a renowned endoscopic surgeon and he is going to deal with a complex topic, that is Mullerian anomalies and its management. And as an expert, we have Dr. Karuna Jha Madam from Jharkhand, who is feathered as first laparoscopic surgeon of Jharkhand. Thank you so much, ma'am, for gracing us and sharing your experience with us. And I would like to welcome further our esteemed chairperson, Dr. Sunita Jha Madam, who is patron, and Vinod Agrawal sir, a renowned name in fertility from Jamshedpur. I'm really looking forward for the panel discussion, which would be going to be mind-storming panel discussion, and will have a scientific and evidence-based approach for the role of endoscopy in different scenario, which is going to be moderated by Dr. Mansi Jain, and who is co-convener of SIG endoscopy. And all the panelists, I want to welcome Dr. Sakshi, Dr. Soumya, Dr. Aarti Jyoti, Anjana Gandhi, Nivedita Mishra, and Dr. Alankrita Madam, Dr. Alankrita Mandal. So now I think we have good numbers of joiners. So without much ado, I hand over the session to Preeti for the further session
Thank
to
you.
continue.
Okay. Thank you, Rupashri. Now we'll move forward to our first session, which is on hysterolaparoscopic management of rare Mullerian anomalies, for which our guest speaker is Dr. Desh Deepak sir, and expert input will be given by our patron, Dr. Karuna Jha Madam, and chairpersons are Dr. Sunita Jha Madam and Dr. Vinod Agrawal sir. Can I have this, Dr. Karuna Jha Madam? Okay. Ma'am is not only our patron patron of IFS, but she is the pioneer in gynae endoscopy, not only in Ranchi, but also from whole Bihar and Jharkhand. Ma'am is, we are so fortunate to have Karuna ma'am here to share her experiences and share her knowledge with us. So, ma'am is MS DGO, DNB, MNAMS, FICS, FICOG, FICMSH, MCH, so many degrees. She is ex-professor and HOD from RIMS. She is the first gynae laparohysteroscopic surgeon of Jharkhand and Bihar, served state government health services for more than 35 years as a faculty in RIMS. She is the chief consultant gynecologist at Bharti Hospital, Ranchi, a tertiary referral center for infertility, management, IVF, ICSI, advanced gynae endoscopic surgeries, and fetal medicine. She has special interest in teaching and spreading awareness of medical sciences. She is former president of ROX and founder patron of IFS. So now, can I have the CV of, I'll request first of all, Karuna Jha ma'am, to please give your expert input after this session will be over. So now, can I have the CV of Dr. Sunita Jha madam, our chairperson for this session? Ma'am is a renowned consultant gynecologist and IVF specialist at Director Sunita IVF Center, Ranchi, CCL. She is MBBS DGO, PGDHA, ex-HOD at Central Hospital GNH, Coal India Limited, lead trainer for medical officers MTP certification course, master trainer for skilled birth attendant, master trainer for ANM's refresher courses, examiner for BSc nursing course, senior visiting faculty at many places in Ranchi, resource person of UNICEF, technical advisor for Kalyani program, vice president ROC, she was in year 15 to 16. At present, she is president ISOPARC Ranchi, and so many academic activities in her kitty. She is a recipient of Dr. Chandravati Award, recipient of Vidya Bhasin Award for Best Paper on Severe Anemia and Pregnancy Outcome at ISOPAR 1995, recipient of Dr. Kumar's Award for Best Paper on Medical Methods for Second Trimester MTPs, presented paper in AICOG 2000 and 2002, 2003. She is a guest speaker at East Zone UA Foxy Conference at Dibrugarh. She was guest speaker at Purvam in 2003 on surgical management of menorrhagia, and she was panelist in strategy workshop on safe abortion and in World Congress 2003. Next slide, please. Okay, that's it, I think. Now I'll request Dr. Sunita Jha, madam, to please introduce our guest speaker for today, Dr. Desh Deepak sir, and our chairperson, Dr. Vinod Agrawal sir. Sunita, madam.
Thank you, Preeti, for your kind words. I think the list is long, so you have taken it very nicely. I take this opportunity to introduce my co-chairperson, Dr. Vinod Agrawal. Sir is a clinical director of Sparsh IVF Center, Jamshedpur. This is the first center of beautiful township of Jharkhand, Jamshedpur. Sir is not only an IVF specialist, he is a wonderful laparoscopic surgeon in the city of Jamshedpur. He is an ex-consultant of Brahmanand Narayan Multi-Speciality Hospital, Tata Memorial Hospital, Mercy Hospital. He is a president of JOGS at present, and he is a founder member as treasurer of Jharkhand chapter of Ishar. I welcome you, sir, as a co-chairperson of this session. I now take this opportunity to introduce our luminary for today IFS Jharkhand webinar, Dr. Desh Deepak, who is also a chairperson for the SIG endoscopy. Dr. Desh Deepak, our today's webinar's hero. Sir is a director of Rajdeep Fertility Hospital and Research Center, Kota, Rajasthan. As a gynae endoscopy expert, he is dealing with the many rare surgeries. Dr. Deepak is a pioneer of advanced endoscopy in IVF cases, and he has a credit of having the first IVF baby and first ICSI baby by him in Kota. Ex-president of Kota OBGY Society. By profession, he is a OBGY, but has a credit of organizing secretary of West Zone Yuva Foxy in 2022. He was organizing chairperson of his State Conference of Endoscopy 2019, State Conference of Rajasthan 2017. Ladies and gentlemen, all the delegates, I am presenting before you our hero of today's webinar, none other than Dr. Desh Deepak. Over to you.
Thank you very much, madam, for kind introduction. And these are the webinars, so we know to each other. I am from Rajasthan, and I came to know so many distinguished guests from Jharkhand, and thanks to Jharkhand IFS Society. So actually, please bear with my throat. I am suffering from viral fever. So please. So first, we should start with classification of the Mullerian anomalies. So this is the classification which is very useful according to sonography guidance. So there are so many classification of the Mullerian anomalies. And one classification is according to the organogenesis, then according to the that was old classification, and this classification which we follow. First, we see that what is the how the uterus appears in 3D sonography. So we all know that normal uterus, how it appears in the 3D sonography, then how the dysmorphic uterus appears on the 3D sonography. So 3D sonography and MRI, two things are very important for diagnosing any Mullerian anomalies. So the my topic is the rare Mullerian anomalies. So I am going to present the video of the this U2 means the variety of the septa, but in that is the Robert uterus, which is a very rare Mullerian anomalies. Then some videos of the Oviara syndrome. In that there is uterus didelphus, and then there is obstruction at the level of the vagina. Then some video of the hemiuterus, and then last one is the MRKH, so aplastic agenesis. So in this classification, you can able to see that uterine morphology plus cervix and vagina, everything was incorporated in this classification. And then we know that what is the abnormality in the uterus, then what is the abnormality in the cervix, and then what is the abnormality in the vagina. Then another classification again is the MEC 21 classification. This is also very useful classification. So we will not go in much detail in the classifications, but one thing is very important, that there are three principles which are very important when we are dealing with cases of the Mullerian anomalies, that all the Mullerian anomalies are always associated with anomalies of the renal tract like kidney, ureter, and gonads are totally separate from Mullerian duct anomalies. So gonads are normal in these type of the cases, and they are having normal secondary sexual character. In such type of the cases, we should always do karyotyping, which is also very important in all cases of the Mullerian anomalies. So there is either there is defect in organogenesis, or there is defect in the fusion, or there is a defect in the septal reabsorption. So if there is a defect in septal reabsorption, so because of that we are able to diagnose these type of the anomalies. The first one is a very rare Mullerian anomaly, is the robot uterus. What happened in normal septa, that cavity is uniformly divided into the two parts, either partially or completely. But in robot uterus, again you can see that in the robot uterus here, that one when we do hysteroscopy, it appears like a unicorn uterus, but from laparoscopically it appears like a normal uterus, and one part of this is not connected to the cervix. So if this part of the uterus is not connected to the external wall, then there will be collection of the blood, and there is formation of the hematometra, and in the future there is formation of the it may cause the endometriosis. So how we can deal with cases of the robot uterus is shown in this diagrammatic representation. So just I am going to start. So this is the sonography picture of the robot uterus, 3D picture. So you can see here that this cavity is totally connected to the cervix and to the vagina. And after the sonography, then there are three types of the robot uterus. First one is the blind hemicavity. You can see this is the type 1, this is type 2, this is the type 3. In type 1, there is more collection of the blood inside the uterine cavity. So you can deal this type of the cases by hysteroscopically only. In type 2, there is thick septa, and it is very sometimes difficult to deal such cases hysteroscopically. Then we can plan hysteroscopy, laparoscopy simultaneously. So in all cases of the Mullerian anomalies, we should have two endovision system in our operation theater, one for hysteroscopy and one for the laparoscopy. And sometime if need arises, then we can shift our sonography machine also inside the OT. So here you can see first is the treatment is the endometrectomy, resection of that part. And suppose in type 1 we can do hysteroscopic surgery, and we can connect this part to the another part. So there will be no collection inside the uterine cavity. If there is any blood collection inside the uterine cavity, then there is chances of endometritis also, and there is always chances of the endometriosis, adenomyosis, and this type, such type of the patient, they are having cyclical menstrual pain, dysmenorrhea, and dysmenorrhea is very severe. Even I have encountered such type of the cases which are referred to me from the periphery. First day, normally this patient was having a right-sided pelvic pain, cyclical pelvic pain, then that pain was continuous. So they consulted the general surgeon. General surgeon, what they did the laparotomy, and they removed the right-sided tumor mass as well as the right-sided appendix also. Again, after 1 month, 2 months, again she developed the cyclical dysmenorrhea, severe pain. Then she consulted in our center. So what we did the hysteroscopy, laparoscopic simultaneously, and then we have planned the resection of endometriectomy in this case. You can see this is the hard nodule of the, just like endometriotic nodule. So we resected all the endometriotic nodules in this case, and also did the endometriectomy in this case. And then after removing all the visible active endometriosis, plus we have resected the myometrium, which involved in this case become adenomyotic, plus whole of the endometrium along with the septa. So this approach is the laparoscopic approach. So I am just using simple bipolar shearer, bipolar cutter. So such type of cases, I can tell you that when we do hysteroscopy, they appears like a unicornate uterus, but on laparoscopic, you have seen that this is not like a unicornate uterus. One thing. Second thing, whenever we do sonography, all the unicornate uterus appears like a banana shape in the sonography, and even in 3D sonography. And so you should know how to diagnose the unicornate uterus in 2D sonography or in 3D sonography, and all cases need MRI also. But sometimes we have to face surprises in the OT table, because this case was operated at the COVID time. She came as an emergency. So sometimes we have to take the decision on the OT table only. So all the part which is affected by the adenomyotic part plus endometrium is resected, and that septa was also resected. Then we did the two-layer closure with using the Statafix. Unfortunately, this patient conceived with one tube only, one left tube was patent, and she delivered 2 baby. Recently, second baby was delivered nearly 2 to 3 months back. So these are type of the cases where we should do proper MRI and proper diagnosis, proper teamwork, so that we can get a good results also. So these are the cases of the Robert uterus, which is a very rare Mullerian anomalies, which I thought I should present in this webinar. Then next cases, and we have published this case also, successful pregnancy in Robert uterus after combined hysteroscopic and laparoscopic management. So what I want to say that such type of cases also mimic like a ACUM. So, but what is the difference between the ACUM and the Robert uterus? That ACUM is always having relation to the round ligament. This is a gubernacular anomalies. Second thing, when we do hysteroscopy in cases of the ACUM, we see both the ostia. So this is the differential diagnosis between the ACUM and Robert uterus. But we should keep in mind that what is the difference between the ACUM and the Robert uterus. So in both cases, we have to do the resection of the that endometrium along with the adenomyotic part of the myometrium. So again, I'm going to share one different type of the septa.
Hello friends.
Sorry.
I'm going to show the variety of videos.
Hello, am I audible? Hello.
Yes, sir, you're
Yes, sir,
audible.
you're audible.
Yeah,
Okay.
you're audible.
This are the different type of the septa in this case, like complete uterine septa, thick and vascular uterine septa, and cervical septa, and complete vaginal septa with complete uterine septa extending beyond the internal os. So in these we have included 3 different variety of the septa and with different instruments. So in one case we use just simple cold seizure in all cases of the infertility if the septa is not much vascular and the thickness is easy to cut with the simple seizure. So we always prefer the simple seizure. And how we are able to know that we have completed the septa, that we can measure the distance from both the ostia, and also we can see both the ostia at the level of the internal os and we can do the transillumination test if we are using two audiovisual system, and we can see the vascularity also. So this is a simple septa. Okay. Then next case was a different variety of septa. In this case, he was having both we can say cervical septa as well as the uterine septa, and this septa was very thick. So we cut the cervical septa with the seizure, and then we have used the excision technique in this case. So either we can incise the septa with the Collins knife or with the seizure, or we can excite the septa. If suppose the septa is a space occupying lesion, then we can also excite the septa with loop of resectoscope. So we are using 2.9 mm telescope with 22 French resectoscope. So we can use 22 French. If we are using the bipolar current, then also we can do septal resection using the 18 French resectoscope. So this is the case where I am going to show you the how we can excise the septa. The third case was the complete vaginal septa. So if there is complete vaginal septa, and if there is a two cervix and complete septa, so if there is sufficient space in the vagina, so there is two school of thought whether we should resect this septa or not resect this septa, vaginal septa. So what we do in such type of the cases, we go in one cavity, and either we can put one Foley's catheter in other cavity, and then we can use the Collins knife, and then we can start cutting just above the isthmus between anterior and just midway between the anterior and posterior uterine wall, and then we can go from one uterine cavity to the another uterine cavity. So you can see here that I'm just started cutting in between the anterior and posterior uterine wall just above the isthmus, and then we can go from one uterine cavity to the another uterine cavity. So such type of the technique we can use in the robot uterus also, but in all such cases we use two endovision system, and sometimes if need arises, then we can shift our sonography machine also inside the OT. So we can start from one corner to another corner. The different technique we can push, or we can, you can see I'm started cutting from one ostia to the another ostia. So this is the one technique, and using the different energy sources and different instruments. So these are all variety of the septa. So after this septa, again we will see the problems where there is uterine didelphys. So in all cases of the uterine didelphys, there is two hemiuterus, two endocervical canal, two cervix, two vagina, can be single or double, each hemiuterus having one fallopian tube. Renal agency is most commonly associated with uterine didelphys. But if there is no any obstruction, there is no any problem, and there is no need of even unification of such type of the cases. But problem arises when there is here there is obstruction in one horn of the uterus. So these are the oblique septa, thick oblique septa, and they are causing obstruction. So there is correction of the hematometra, and which will further lead to the endometriosis also. So this is the MRI picture of the oviara. So this is the obstructive hemivagina with ipsilated renal agencies. So MRI is also very important in such type of the cases. So in the MRI, you can see here that this is U3B, bicorporeal uterus, complete bicornuate uterus, as you can say. No hematometra. Sometimes cervix is very thick valve, so there is no chances of hematometra also, and septate cervix and vagina. V2 longitudinal obstructive septum, they have written in the MRI. In whole abdominal sonography, non-visualization of the right kidney. So in such type of the cases, we should always look for the absence of the kidney. So now this is the laparoscopic view of this case. So this is a young girl, unmarried young girl, you can see the fullness. Here is you can see the fullness. So we do hysteroscopy and laparoscopy simultaneously. So there is first we can just do proper diagnostic laparoscopy, and after doing proper diagnostic laparoscopy, then we have started doing gynecoscopic approach. So in this case, you can see the cervix. So first we go inside one cavity. So you can see here that this is the cervical canal, and then we go inside the cavity, then we can see only single ostia. So this is the single ostia. Then you can see here there is a bulge from the right side. So first we start from the cutting with the Collins knife. So in such type of the cases, it is very important that we should excise the septa. Not only drain the septa, excise the maximum part of the hanging part of the septa. So first we you have seen that initially I used the Collins knife. After that now I am using the loop of the resectoscope so that we can excise the redundant part of the septa. So even we can excise this part of the septa with cautery also, simple open cautery also. So what is the important thing is here that we can try to excise the maximum part of the this thick septa. And now both the cervix are visible with gynecoscopic approach, and then we can go to the another part of the this uterus. So maximum these are the patient if we diagnose in a proper time, so the results are very good. But here I want to say one thing that if the diagnosis is late, and suppose if we have given just a simple nick, then there is chances of infection. So this is the case where there is diagnosis is late. And one thing is also important, sometimes few patients they are not having the cervix also. So in this case there is cervix was not developed, and there is complete infection in the fallopian tube. There is pyosalping. So we have to remove this left side of the fallopian tubes, and not only fallopian tubes, the remaining part of the uterus was also diseased and adenomatic because cervix was absent in this case. So we have to, sometime we have to do the hemihysterectomy also in such type of the cases. So this is the video of the hemihysterectomy of this the case which was not having the part of the cervix. But in this case, why we did the hemihysterectomy? Because this part of the uterus is also diseased. There is no any attendant, they don't want to take any chance of the pain because she was having severe pain, and the part of the fallopian tube was also diseased. But we should always left the healthy ovary. So this is another case which was diagnosed very late. So these are the cases which I want to share. First one, I have already shown you the video of the robot uterus, then the oviara. So after these Mullerian anomalies, now we will go to the unicornate uterus. So these are the Mullerian anomalies. Mainly one part of the Mullerian duct is developed properly, and another part of the Mullerian duct is not partially developed. But if suppose this part is having functional endometrium, then this part of the uterus will create problem. So these type of the unicornate uterus always associated with the urological anomalies in 44% of the cases, and poorest fetal survival among all Mullerian anomalies because of the insufficient muscular mass, decreased uterine volume, and decreased ability to expand. Non-communicating accessory horn having endometrial cavity, most common and most clinically significant, can cause hematometra and endometritis. So these are the cases which need removal. And what are the tips and tricks while we are doing hemihysterectomy in such type of the cases, which I want to share with you. This is a 16-year-old girl presented with severe pain in abdomen during menses, gradually increases in severity and intensity. She was investigated USG defined rounded lesion of 3.4 into 2.6 millimeter with peripheral thick hypoechoic rim and central cystic area. So you can now see in this case that this is the part of the uterus which is not communicated, and she was having a severe dysmenorrhea in many cases where we did removal of such type of the hunch. They have already taken either Dynogest for 6 months or Lupride pot injection, but ultimately such type of the non-communicated heart we have to ultimately remove them. So first step in such cases that hysteroscopy and laparoscopy should be done simultaneously. I'm trying to see the ureter in few cases, and we can also find out the uterine artery at its origins. So we have already did hysteroscopy. You have seen in the PIP that right-sided cavity is communicated to the vagina and appears unicornate, and left-sided uterine horn was adenomatic and not communicated. So after visualizing the ureteric peristalsis and then so we can see the ascending branch of the uterine artery. We should take care that we should that another the blood supply of the another part of the uterine horn should not be hampered. And then we are creating the window. Here we are creating the window in the broad ligament, and ureter is also well protected, and which can preserve the ovary also. But there is no any use of the fallopian tube in such type of the cases. One thing is very important that we should always suture the lateral margin of this with the statafix. That is very important, and then always transfix with the round ligament. So this part is very important, which I want to share, that proper suturing, so that in the future there is no any chances of the impending rupture. So closure of the left lateral wall defect is done in 2 layers, and we can suspend this part again to the round ligament of the left side. Sometime round ligament becomes short, so we have you can see here that how we have dissected the round ligament on the left side, and then fix this part to the remaining portion of the. Here we can again tie these two portions so that it provides a proper support to the uterus. And even we can support the ovary also, like that. Okay. So this part is very important. So again, am I audible?
Yes, sir.
Okay. Now I am going to share another video of this patient. This is the case of non-communicated pregnant uterus. Sometimes I have encountered 2 to 3 such type of the cases where the pregnancy was there in the non-communicated heart. And surprisingly, one patient referred to me where the baby was swimming inside the abdominal cavity, because the diagnosis was not made properly, and they are putting the misoprostol for termination of the pregnancy. So proper diagnosis is very important. And whenever we are operating in the pregnant uterus, there is chances of the bleeding also, and we cannot manipulate the uterus in such type of the cases. So proper anatomy, and we can even ligate the uterine artery of this side, and then again we can drain in the sac also, or we can pull from the central port like this. So these are the cases which we encountered in emergency also. So it is very important to diagnose them as early as possible. So another agencies, now we move to the cervical agencies. So these are also the very challenging cases where there is cervical agencies, because in such type of the cases, if we diagnose and treat such patient as early as possible, then there is less chances of the endometriosis, pelvic pain, and adenomyotic uterus. And you can now we can start our video. So this is a patient with cervical agenesis. Now you can see that there is a grade 4 endometriosis, active endometriosis, because of the retrograde discharge of the menstrual blood. So first we have fulgurated this all active endometriotic nodules. Then in such type of the cases, we are going to anastomose the uterovaginal anastomosis, and the vagina and the anastomosis is made between the uterine wall. So this part of the cervix which is not canalized, and because of that the uterus was adenomyotic. So we have to dissect that part of the cervix, and then bladder is mobilized, the rectum is mobilized from the posterior side, and sometimes 3D helpful, very helpful in such type of the cases. Here we are able to see in like 2D picture. So mobilization of the rectum, then mobilization of the bladder, and then we can see the ureter of the both the side. So in such type of the cases, what we do, we just mobilize the bladder, and then we can give a transverse cut in the anterior vaginal wall. So we can put a rectal probe in the anterior vaginal wall. Then here we are giving the longitudinal cut, and the part of the uterus and the cervix was very hard, so we used the harmonic scalpel, and then all the active endometriotic and adenomyotic part of this uterus is removed. Then after removing the non-canalized part of the cervix and adenomyotic part of the uterus, we have given the transverse cut in the anterior vaginal wall. After, in such type of the cases, there is always chances of the stenosis also. So proper dissection is very important, and then we can put a silicone catheter, wide bore, 18 number or 16 number, and these are all the adenomyotic tissue which is removed. Video quality is not so good because of the adenomyotic tissue. This part is very important. See, first we have taken the stitches with the Prolene at the both angle, from the right side and the left side. So these are the stitches which are taken from the lateral part and the posterior part of the vagina and to the posterior part of the uterus. So after taking the stitches on the right side, then we are taking the stitches on the left side. So angles are stitched with the prolene, and after the stitching both sided angle, then posterior side anastomosis is done. So this is the stitches which are taken on the both angles are tied. After that, we can put after posterior anastomosis. This is the posterior anastomosis. Few stitches are taken from the posterior vaginal and the posterior wall of the uterus. Then here you can see that this catheter should be kept for at least 1.5 months. So we can also stitch this catheter with the Vicryl. Vicryl will dissolve. Reproductive outcome, I don't know, but this patient was having continuous menses after this surgery, and we did this surgery 2 years back, and she is coming in continuous follow-up. So there was no stenosis. She was having proper menses also. So finally, these are the very challenging cases. And after doing this anastomosis, then we can do the gynecoscopy also in such type of the cases. So this is the we are doing the gynecoscopy also, and follow-up also very important. This is sonography picture. So these are the cases which are very challenging, and sometime if there is a stenosis, then we have to counsel the patient that you may need hysterectomy also. But so in the last video is the agenesis of the uterus, that is known as MRKH, and this last video which I am going to present is the peritoneal pull-through operation. So this is a very rewarding operation because in previously we are using the skin graft and creating the space between the rectum and the bladder. But suppose if we mobilize the peritoneum and if we use the peritoneum as a graft, so there is less chances of the stricture formation in the future, and they are having a very satisfying sexual life. But what is the important in all such type of the cases, that mobilization of the peritoneum should be adequate and should be tension free. So in all such cases also we have to visualize the ureter and mobilize the rectum, and initially there is always difficulty in dissection also, and we have done the rectal injury in initial few cases, but after proper anatomy, understanding the anatomy, there is a good patient outcome. And one thing is very important here, that we should cut the vaginal plate, because vagina is developed from both sinovaginal bulb and upper 2/3 of the Mullerian duct. So this vaginal plate, this plate should be cut sufficiently, because there is always chances here. So we are using the rectal probe, and just above the rectal probe we have cut this sufficiently. And after cutting this part of the peritoneum will go to the posterior side, another part of the that will go to the anterior side. This part will go to the anterior side. So I'm just forwarding this video. So we have mobilized the peritoneum from all the sides, and even we can mobilize the peritoneum from lateral side also, so that both the ovaries will come in the middle. So in the future, suppose they want their genetic child, so we can do the pickup also. So these ovaries should be kept in the middle. So I'm just mobilizing from the lateral side also. why we are doing such extensive dissection? Because we can get the sufficient peritoneum, and there will be no any stretch on the peritoneum also. So we are trying to mobilize as much as possible. So dissection is done, both sided ureter is visualized, and both the ovaries are kept in the middle. Now we can make the apex of this vagina. So we are not able to show you the vaginal end at the same time, but we have given the posterior part peritoneum to the one team is working vaginally. So in the vagina we make a U-shape incision, and then the team who is working at the vaginal end, they pull the part of the peritoneum and after that we are making the apex, and we can take the one part, the serosha of the rectum. So if we do proper dissection and proper mobilization of the peritoneum and proper cutting of the vaginal plate, so there is less chances of the stricture formation, and such patients they are keeping their mold very easily, and normally we plan vaginoplasty when they are going to marry for 3 to 6 months before the marriage. You can see both the ovaries are also came in the center, and then we have closed the apex, made the apex, and so these are the mold which are made by the dentist, also by dental, or we can make with the 20 ml syringe, and we can examine this patient. There is always entry of the two finger. Now the last video, in such type of the cases, there is one of the complication occur when we are doing a case of the non-communicated hernia of the uterus, and laparotomy was already done. So the bowel, the bladder, every things was adherent to the each other. So these are the redo cases. So there is always chances of the bladder, bowel, or rectal injuries. So thank you very much. I think I have crossed the time. So in nutshell, obstructive uterovaginal anomalies may present after puberty with amenorrhea, dysmenorrhea, pelvic pain, recurrent vaginal discharge, or infertility. If the diagnosis is not certain, or there is a concern for a distal vaginal atresia, transverse vaginal septa, cervical atresia, or an obstructed uterine heart, magnetic MRI is recommended. Simple incision and drainage of the hematocarpus should not be performed because it is associated with the high rate of the ascending infection and sepsis and may complicate definitive surgery. The best long-term outcome is achieved with the complete evaluation and clear understanding of the anomalies, mobilization of the appropriate surgical resources, sufficient pre-operative counseling, and planned surgical interventions. Thanks for the patient sharing. Thank you very much.
Thank you very
Thank you.
much, sir.
Thank you, sir, for your excellent talk. And we are all spellbound for we didn't know when your time has overshooted. Now I hand over my mic to Dr. Vinod Agarwal, my co-chairperson, and then to Dr. Karuna Jha, madam, to give the expert opinion.
Sir, it was a feast to watch your surgeries, and really what Sunita ma'am said, your overshooting the time was never a concern. I don't think anybody was looking at the time. So the basic 2-3 take-home message is that MRI plays a very important role in these cases,
Yes.
where you have to put up a diagnosis rather than going directly invasive into laparoscopy and all. So we need to come to the diagnosis as closer as possible, and MRI plays a very definitive role for that. Secondly, in cases of removing a rudimentary horn or something like when you are doing a hemihysterectomy, the lateral margins must be stitched and not relied upon only the electrosurgical part. So those 2, 3 things are really very worth watching, and those take-home messages. Thank you, sir, for your excellent presentation, and I hope it was a feast.
Sorry, I was suffering from viral fever. That's why my
Oh no, sir, you were very much clear. You were
uh,
very much clear. Yeah. Thank you, sir.
Thank you so very much, Dr. Deepak. And you have got a vast collection of all those videos. You have already done those surgery. Wonderful. One thing I just wanted to know from you, like you said about the cervical
Genesis.
illnesses. And in that patient, you had joined the uterus along with the vagina. Anteriorly and posteriorly, you cut the vaginal portion and then you stitched it together. That's okay. So now the patient will have her menstruation every time regularly.
Yes.
That's fine. Have you followed up such cases where they can conceive? If they conceive, then what happens? There's no cervix. Whether there will be retention of the pregnancy till viability of the baby fetus or not in such cases.
Very frankly, I'm just following this case from the last 2 years. I did only 2 or 3 cases, not much. And in the beginning of my career, we have to sometimes facing the failure also. We have to do the hysterectomy also. But in this case, she is having proper menstruation and she is very satisfied as far as the dysmenorrhea part is concerned. So let us see when she get married, and then I will do the follow-up also, and then we can plan. I think laparoscopic cervical insert class, because there is always chances of the incompetent or because cervix is not there. So how she will retain the pregnancy is again a really very question mark. And then I think in such type of the cases we can put a Marceline tape at the level of isthmus at the 12 week of the pregnancy, during pregnancy. But such type of cases where there is like unicornate uterus, so there is always chances of the pregnancy losses. So we can do laparoscopic cervical insert class. Hello? Oh.
The follow
Thank you very much, sir. Now we are heading towards our next session. Preeti,
Yes, ma'am.
I hand over mic to the Preeti. Yeah.
First of all, thank you very much, Deepak sir. It was really outstanding and excellent presentation. Thank you very much for showing us such rare anomalies like Robert uterus. I'm sure many of us never seen such cases. So thank you very much, sir, for this
Thank you.
excellent presentation. And now, before moving to next session, today is Women's Day. So first of all, I will like to wish all the beautiful women here happy Women's Day. And now we'll move to our next session, which is a panel discussion on role of endoscopy in infertility. And moderator for this session is Dr. Mansi Jain. And our panelists are Dr. Aarti, Dr. Soumya, Dr. Sakshi, Dr. Anjana, Dr. Nivedita, and Dr. Alankrita. So here is the CV of Dr. Mansi Jain. She is MS, Diploma Clinical ART. She has done fellowship in reproductive medicine and surgery from Singapore. She is consultant reproductive medicine and gynae endoscopic surgeon at KJ IVF and Laparoscopy Center, Delhi. Then she is co-conveners SIG endoscopy, IFS. She is executive member of IFS, national coordinator SIG and IFS. She has done fellowship in reproductive medicine from Thomson Fertility Center, Singapore, fellowship in minimally invasive surgery from Max Hospital, Saket. She has presented papers in various national and international conferences, written multiple chapters in books, delivered lectures and video presentations as national faculty. She is adept in advanced OBGYN and ultrasound. She is a keen academician and research with special interest in reproductive medicine. She is a national coordinator ultrasound IFS. She was organizing secretary pre-Congress workshop AOGD 2019, and she won second prize in paper presentation ISAR 2016. So now I will request Dr. Mansi Jain to please introduce your panelists and start the session.
Thank you,
Dr.
Dr.
Mansi.
Preeti. Yeah, thank you, Dr. Preeti, for the kind introduction. I welcome everyone for this joint collaboration between Jharkhand chapter and SIG Endoscopy. At the outset, I would like to thank Rupa Shri Madam and her entire team, and I would like to congratulate her for seamlessly organizing today's webinar. I also take this opportunity to introduce my SIG to you all. Well, SIG Endoscopy is a special interest group of IFS, and we have a brilliant and a very dynamic team, which is mentored by none other than Dr. Professor Kuldeep Jain, and the convener is the very famous Dr. Parul Kotadwala sir, and Dr. Desh Deepak and myself, we are the co-conveners. So we have an aim to spread the correct and the ethical practices of endoscopy in the infertile population. And we have been collaborating with various chapters and various societies all over India. In fact, this year we look forward to a lot of significant international collaborations as well. We also have special endoscopy squad group, which comprises of 12 members at present. And these members are constantly in touch with us and contribute significantly towards our SIG activities. Also, I take a lot of pride in announcing that this year we also won the Best SIG Award at the annual Fertivision. And with that, I would like to personally invite you all, everyone who shares a passion and love for endoscopy, to join us and become members of our SIG Endoscopy. So without wasting further time, I would just take 1 second to just share my screen so that I can invite my panelists. So is my screen visible? Hello, supporting. Can you help me with that? Is my screen visible to everyone?
I don't think.
No, not visible.
No,
ma'am.
not visible.
Okay, just I need 1 tiny second here. Okay, I believe now it should be visible.
Yes.
Okay, perfect. So it is my absolute privilege to introduce and invite a brilliant panel of our panelists today who will be helping us solving our common challenges that we face in our day-to-day practice. So I invite Dr. Aarti Jyoti. She's a consultant at Ma Ram Pyari Super Speciality Hospital. She has various awards and achievements to her credit. She's an active member of ROGS Jharkhand, co-chairperson of Gynac Endoscopy Society ROGS. She's also the operative faculty ROGS Yuva Conference, and she has been speaker and faculty at various national conferences. Next, we have Dr. Soumya Sinha. She's the director of Bella Fertility IVF and Laparoscopy Center. She's also the chairperson, minimal invasive and major surgery. She's also the committee member of Ranchi Obs and Gynae Society and an executive member of IFS Jharkhand chapter. Next is Dr. Alankrita Mandal. She is a consultant and gynae laparoscopic surgeon at Sheila Rani Hospital and Fertility Center. She has received the highest MTP Achievers Award in Jharkhand in 2017. Then we have Dr. Sakshi Singh. She is the secretary ISAR Jharkhand chapter and the joint secretary of ROGS in 22-23. And then we have, Dr. Anjana Gandhi. She's an accomplished general surgeon in Jharkhand with a proven track record in laparoscopic and trauma surgeries. And then we have Dr. Nivedita Mishra, senior consultant, IVF and fertility gynecology. So I welcome everyone. Well, we all know that implantation remains to be the rate limiting step in IVF. over the years, there have been various advancements in the field of reproductive medicine. But despite having good quality oocytes and a good number of blastocysts, still the success rate of IVF remains to be reaching a plateau. So implantation just remains to be the rate limiting step in IVF. So my first question to all of you would be, and I would like all my panelists to answer this, that in your routine practice, how do you evaluate the endometrium? So I would like everybody to answer this. We can start with Dr. Sakshi.
Is Dr. Sakshi there? I think she has not joined yet.
Okay, so is Dr. Soumya there? I can see Dr. Alankrita. Madam, would you like to take this question?
Routine practice, usually I evaluate the endometrium by TVS ultrasound. And if I find any difficulty in TVS ultrasound, if there is any findings in ultrasound, then I go for hysteroscopy. Yes, hysteroscopy is superior to USG in endometrial evaluation, but routinely I use TVS ultrasound.
Okay, can we have any comment from somebody else? Dr. Nivedita, is she there?
Yeah, hi, Mansi. Actually, yeah, the first step is always a 3D ultrasound or a TVS ultrasound. And if there is an issue in ultrasound, then also we can proceed to hysteroscopy. But hysteroscopy had some added advantage in the sense of chronic endometritis, sometimes which is cannot be picked up in ultrasound. So, if there is any particular findings in endometrium, which is like we can elicit only in hysteroscopy. So hysteroscopy can be used as a supplement to TVS ultrasound, not routinely done, but in the cases if they are having an implantation failure, in spite of good embryos, then we can add on with the hysteroscopy.
Okay, very nicely said, madam. And since you mentioned 3D ultrasound, so the next question will be, do you use routinely 3D ultrasound in your practice, or is it only for a selected group of patients?
No, I don't use in routine practice. I usually do in the cases if there is an septum or if there is any polyp is suspected, then I do 3D ultrasound. I do in cases of isthmosele also, or if there is an hydrosalpinx, like in these routine cases, it is usually done. Otherwise, an ultrasound with a Doppler study is good enough.
Okay. Dr. Anjana, is she there? No. Do we have any other panelists? I can see a lot of people. I'm not able to make out really.
Excuse me. Considering hysteroscopy to be invasive, USG is always a better option. It should be done before any invasive procedure. So I will go for USG first. Until unless there is some difficulty and you want to go for hysteroscopy, then it's good. But initially start with USG.
Very, very nicely said. Well, we all know that definitely hysteroscopy does score over ultrasound in terms of accuracy, sensitivity, and specificity. However, one cannot eliminate the role of ultrasound. Ultrasound remains to be the baseline investigation. Also, I would like to add on to this, it's not only ultrasound, the evaluation starts with a simple HSG also. Although it is not the modality of choice for evaluation of the endometrium, but however, signs like intrauterine adhesions can be picked up on HSG as well. So we all know hysteroscopy definitely has an advantage in terms of, it is a see and treat modality. It is not only for diagnosis. And I would also like to ask here, what is your experience with office hysteroscopy? Is it something that you're doing routinely? Alankrita, madam?
No, patient doesn't allow office hysteroscopy. I always used to do in the OT only under mild GA, mild anesthesia. I don't do routinely office hysteroscopy.
Anybody else using office hysteroscopy?
Yeah, myself, Dr. Aarti. Am I audible?
Yes, madam. Yes, madam.
Yeah, so I was trained at Mumbai. There routinely we were doing, I was trained under Dr. Harish Vagasia. So we were visiting a lot of IVF centers where routinely we were doing office hysteroscopy using 1.9 mm scope. So definitely it's not that easy. You have to be expert, first of all. Second thing is you need to counsel the patient and you need to be fast with your treatment. I mean, one who has got good expertise with hysteroscopy. But it has advantages in cases of infertility hysteroscopy, definitely. Because you are not going to harm the patient or touch the normal endometrium or the myometrium because patient is not going to allow. The moment you are going to touch the normal uterus or the normal endometrium or the myometrium, the patient is going to wince. So it's a very good guide if you're using an office hysteroscopy. What happens when you're doing something in under GA, you're just going on and on. Supposedly you're cutting a septum, removing a polyp. It's like it's an endless kind of procedure because the patient is under anesthesia. But I have seen when servers doing office hysteroscopy, although I'm not practicing at present, the patient definitely used to wince with pain if he was removing the fibrotic endometrium and suddenly was touching the normal endometrium or the myometrium. When he was doing the septa resection, in that also patients is a very good guide, the pain approach of the patient. So I would always suggest that it's a good practice, but at the end, I would like to say that expertise definitely matters. I have seen using resectoscopes. We also know that office resectoscopes have also come into use. So, in my opinion, we should make a target in case of infertility hysteroscopy to achieve that goal. But if we are starting and doing and getting trained and we are still in the learning curve, it's better that we do a hysteroscopy using a 2.9 mm scope under short GA or something like that. It's my opinion, what I have seen and practicing at present.
So yes, even I agree. Office hysteroscopy, although it's very useful, but it comes with its own set of disadvantages. You need to have a proper setup in case you need to convert it into, a long case. So I'll be sharing, and especially with the advent and, now 3D ultrasound has become so common. So definitely ultrasound with the wonderful high frequency probes we are having these days. So even if you're not having a 3D, I think the diagnosis part has become very, it's become very easy with an good ultrasound machine. So I'll just like to share my experience. So we've done over 500 cases where there was a correlation between the TVS 3D and hysteroscopy. On grayscale, that is 2D, 60% cases were in agreement with the findings, and 3D helped us to take this number higher up to almost 80%. However, everything needs to be taken with a pinch of salt because what we notice is around 10 to 15% pathologies were over detected on 3D. So, 3D again has its limitations. You need to acquire the right images. At times, it's just an artifact. And in my study, we have seen that 10 to 15% was the false positive rate. So the take-home message here I would like to highlight is that all modalities, ultrasound and hysteroscopy, should be used complementary to each other and not be seen as competitors.
Here I like to add one thing, like because both the 3D ultrasound as well as hysteroscopy, these are very subjective things. Observer dependent, relies mainly on the skill. So I totally I would suggest that anyone who's adept with which modality, like if someone is very good at 3D ultrasound, he will or she will be better in diagnosing or managing patient with ultrasound than with a hysteroscopy, and vice versa. And definitely the cost factor plays a major role in our country as whole, not just Jharkhand, but everywhere. 3D being non-invasive and low cost is more acceptable by the patient, and it's very useful in counseling and convincing the patient for going for a operative hysteroscopy if at all required.
Yes, definitely. Proper expertise and training is must for 3D. So very quickly, I would like to quote the ASRM Exchange Session 2018 conclusion. So surgical procedures that can influence IVF outcome, hysteroscopy combined with 3D ultrasound provides the most accurate assessment of the uterine cavity. Which brings us to the first case for today. So, Mrs. S.A., 28 years, married for 4 years, conception. She has scanty periods for the last 2 years and no other complaints. And there was no history of COX. The seminal parameters are within normal limit. She has already received 3 cycles of ovulation induction. So, what would you like to do next for her?
Are you like, is a question open to the house, or you
Yes,
are?
it's open. It's open. Anybody can take it. Dr. Soumya, I can just see your table. We cannot see you. Can you please?
Actually, I don't know, but I am not able to see my video, so that's why I am not able to focus.
Okay, we can see you now.
Just 1 second.
Yes, we can see you perfectly well.
Okay, so because she has already received 3 cycle ovulation induction, and nowhere, like in the case history or somewhere, it is given what were the endometrial lining, because her period were scanty. So during the ovulation induction, how the follicles were, what were the size of the follicle, and what was the thickness of the endometrium. If there is no problem with the endometrium, so mostly if the good follicle is growing, so endometrium will be able to produce sufficient thickness of endometrium. But in spite of having a good follicle with good vascularity, the endometrium is not good, and there is no report regarding the tube test. So if these are available, so we have to evaluate for her uterus as well as the tube. So better to go for a diagnostic histolab in this case. After
Would you like
after a tube test.
Yeah, so would you like to go for an HSG first or a histrolab first?
Definitely HSG, but now because HSG is a very painful process, so because of very easy availability of the information, most of my patients themselves demand that they don't want to go for HSG, so we opt for SSG, sonosalpingography. The that is also the result of sonosalpingography is not as good as HSG in making a making a decision. So if HSG is there and patient is very keen on getting HSG and the reports are there, the tubes are open, then there is no question regarding evaluation of a tube point. But because you are saying scanty period for 2 years, and if it all is there, so we need to at least evaluate the uterus.
Okay, does anybody
We should also do we should also do the hormonal evaluation, where we should find out the cause of scanty menses. We should do the blood
hormonal
test.
evaluation is normal, all within normal.
Hormonal evaluation is normal, then we should go for hysteroscopy and under directed hysteroscopy we should take the biopsy also, because no history of COX in our Jharkhand area. Tuberculosis is very prevalent. So if the hormonal evaluation is normal, her tubes are patent, and she is having a scanty
But we don't
periods,
know if the tubes are patent.
we should go for SSG. I usually first do SSG hormonal evaluation and then I put the patient for hysteroscopy. I do SSG myself, so I have the, I think it is better than HSG. It's give complete evaluation of the uterine cavity, the mobility of the tube. So SSG is, I should go for SSG first.
Does anybody else to differ in this?
Definitely hysteroscopy must be done in this case.
Yeah, I also totally agree, because the main problem here is scanty flow for 2 years in such a young patient, 28-year-old. So endometrial evaluation is must. And for that, I think hysteroscopy is going to help the patient. As it is, she has already 3 failed cycles of ovulation induction. So I think
we got an HSD for her because we don't have any information about the tubal status, and this was the picture in HSD. Can anybody comment on the picture? Would anybody like to comment?
Yeah, it is a case of Asherman syndrome. And this may be the cause of her scanty periods. There are filling defects in the HSG.
What would you like to comment on the tubal status, madam?
The tubes are, at the end, the fimbrias are blocked. There is no free fluid in the POD. So this definitely needs laparoscopy as well as hysteroscopy.
Yes, so perfectly said, madam. We can all see here, we can see the endometrial factor here. We can see the septae, intrauterine adhesions, not septae, sorry, the intrauterine adhesions. And although there is pill on both sides, but it seems to be a fimbrial agglutination. So that completely changes our, the
Management approach.
management of an approach of the patient. So what would you like to do for her now?
Obviously, diagnostic hysteroscopy followed by operative, this resection, making of the cavity, treatment of Asherman, and patient should be properly counseled. And we have to see what was the reason of these Asherman from her history, going deep. If she had previous any miscarriage for which DNC was done, something like that. And in laparoscopy, we would look for signs of Cox abdomen, if at all is there something, and send the
You would like to
samples.
do a laparoscopy also along with the hysteroscopy?
Yes, because fimbrial block is there, na? So
Yes,
it's
definitely.
better to see
So
the tubes from
hysteroscopy
outside.
combined with laparoscopy and not only diagnostic, we should definitely aim at corrective surgery. And yeah, so that should be the treatment. So my next question would be, do you offer hysteroscopy in all cases or only in a selected cases?
In selected cases.
Yes. Anybody else doing it routinely? I don't think so, right?
Not routinely.
Yes. So our approach to hysteroscopy is that all patients are thoroughly scanned, baseline ultrasound 2D, as well as since last few years we've added 3D also to our practice. So that is what we are routinely doing, and only the patients with a suspected pathology, the repeated IVF failures, any abnormality on TVS or HSG, if there's a history of COX or PID, or poor endometrial growth, or history of repeated abortion. So these are the patients who are taken up for hysteroscopy. This seems very obvious. Does hysteroscopy improve the chances of conception?
Yes.
Yes,
Yes,
Yes, yes.
So let us quickly look at the evidence. I don't think we have any debate here. We have moderate quality evidence that hysteroscopy increases the pregnancy rate if performed before IVF, regardless of the intrauterine abnormalities. Moderate quality evidence that hysteroscopy may increase the pregnancy rate when removing some mucosal fibroids or endometrial polyps. However, we need robust and high quality RCTs are still needed, that if hysteroscopy should be made as the first line procedure for
So
all patients.
here I have one question. Like previously, routinely for IVF patient who were patient who were undergoing IVF, routinely hysteroscopy followed by the endometrial scratching was done. So now
Madam, there is no evidence or no guideline supporting that. There are two schools of thought. One advocates the routine use of hysteroscopy for evaluation of the endometrium before going for ART procedure. The second school of thought is that only in suspected cases. So the debate still goes on. And that is why we still need a lot of, RCTs and meta-analysis to formulate the guidelines whether hysteroscopy to be made the routine investigation for first line. Yes, exactly. So which brings us to the second case, Mrs. S, 28 years old. She's having scanty periods, diagnosed as genital tuberculosis and blocked tubes during workup. She has already received ATT. Irregular and patchy proliferation was seen during evaluation. So now we have decided to put in the scope, and this is on table that she's diagnosed as Asherman grade 4 on hysteroscopy with only 30% of the endometrial cavity available. Now you're sitting in the OT with the scope inside. What will be your plan? Dr. Nivedita, would you like to take that one? Anybody can.
Yes, because she was previously diagnosed as genital TB with blocked tube during workup. So during before pre-operative only, we should have counseled the patient regarding the need of operative. There may be need of operative operative measures to be taken during surgery. So if SMN grade 4 is diagnosed in the same sitting, if the patient and the couple has been explained previously and the proper consent has been taken, we can go ahead with adhesiolysis for creating the whatever cavity we could create, and then going and after relook surgery, then following up with ultrasound to see what like, and giving this estrogen to see the proliferation of the endometrium, how it is reacting to growth. Endometrial growth is regarding after giving estrogen, and after follow up, if it is not adequate, we can go for PRP, platelet rich plasma therapy, and now the stem cell therapy is also available. So depending on the need, we can give a try to the patient, because now as surrogacy is very difficult, we have to give a heart and soul to this case. So we can develop a good endometrium and she can conceive.
Yes, so very important whenever you encounter such patients or any patient you take up for hysteroscopy, the idea is always to not only do the diagnosis part, because otherwise we will not be taking full benefit of the procedure. So it's always operative. So whenever you take up your patient, it always has to be with the understanding you don't only just see, you correct at the same time. When we talk about cases of Asherman grade 4, so extensive adhesiolysis, and like Dr. Soumya said very rightly, you have to try and regain as much of the cavity as possible. What are the common, problems and the challenges you face when you're operating on a grade 4? Dr. Aarti, would you like to comment on that?
See, first of all, whenever you are doing first and the foremost thing which you have to be afraid of is doing a perforation and making a false passage. Because with grade 4 and 30% of cavity, it's almost blocked. Nothing is there. So first, explain the patient that you will need a second look procedure. Second look, at least, maybe a third look may be required. And create the cavity using cold scissors. Never use energy. Many of us are in a way to use a resectoscope lying and then start doing. You're not going to benefit, you're going to harm. Maybe you are leading to 100% obliteration. So cold scissors only, as much as you can. And always, I don't know, if you are a beginner, you can always, if the patient gets counseled, we have seen cases where we have to put a laparoscope, and under that guidance, we were creating a cavity. That was actually failed attempts of hysteroscopy. 2 more surgeons had tried and created a false passage. And then again, we were doing hysteroscopy for such a patient. So that can also be a guide for you. Otherwise, don't be in a haste of creating full cavity. You cannot in such cases. You need at least 2 to 3 sittings, when even if you are giving high dose of estrogens and progesterone, giving adhesion barriers, whatever you are using. But with without 2 or 3 sittings, such patients are not going to benefit a lot. So only 2 most important points. Don't be in a haste to create a big cavity or complete cavity, and don't create a false passage, and use cold scissors without any energy.
Very important points highlighted there. Anybody wants to add something to this?
See, the
I
best
totally
part
agree.
about this is the patient is at least getting a menses. If she's getting even scanty menses, it is this have a good prognosis. So once you do this after this clearance of adhesions, and I believe that as much as you can do in one sitting, it will be good. And then if you can do a instill PRP, and if stem cell is available, then stem cell therapy is one of the best method.
We are just
And
focusing on the intraoperative part. Any challenges that you face, any complications, and what are the ways of avoiding it?
then you at least you have to be prepared for laparoscopy, because sometimes there may be adhesions, there may be you may cut through the uterus, or there may be perforations may happen. So it is prior counseling for laparoscopy is important.
So yes, the risk of perforation is one of the major risks that one encounters if you're not inside the right plane. So you can it's very easy to create false passages and also to, perforate the uterus. Laparoscopy is one way, but what we routinely do is take help of intraoperative ultrasound guidance, which has proven to work wonders in these cases, because the problem in these cases is that you don't have any landmarks like the ostia, which are usually the landmark in a normal case, so are mostly obscured in such cases. So the problem is where to begin. So that is where intraop ultrasound can definitely help. And the other complication one encounters is the problem of fluid overload. So because these are the cases that will take a lot of time, so you have to be extremely watchful about the fluid deficit. In fact, there has to be one person in the OT that takes into account only the fluid deficit. And if at any point of time it exceeds above 1200, so you have to abandon the procedure. And that's why it's very important to pre-counsel these patients about a need for a relook hysteroscopy. So in this case, an
Just
extensive
adding one point, Mansi, in my experience, most of the Ashermans have tubal blockage. So this problem of fluid overload doesn't happen with them. Usually they're ostia or ossified. We don't have fluid overload in these kind until this is kind grade 4.
Yes, madam, but we have to watch the fluid that is
Yeah, of
the
course, we have
deficit
to
is
go with
there.
normal saline or
Yes, so like if any point of time the deficit exceeds over 1 liter or
yeah.
maximum you can go to 1200, so you have to be extremely
Yeah,
cautious.
yeah, that has to be there. That has
Yes.
to be there.
So in this case, extensive adhesiolysis was done and the cavity was restored up to 80%. Another important thing in this, like, has already been discussed, but I would just like to throw more light on what is the protocol for post operative adhesiolysis here, because you've done extensive adhesiolysis. There are chances that the raw areas will tend to so what is your
You
preferred
put Foley's catheter with just 3 ml, with a bulb inflated with just 3 ml of fluid, and we remove after 3 days or 7 days, depending, and then we follow with ultrasounds.
Anybody else?
Yeah, if there is bleeding, then
Extensive.
Foley's, otherwise nothing. We just start the estrogen preparation.
For
So you
this
do,
type of grade 4 adhesiolysis, Foley should be kept for 10 days at least, since it is extensive adhesions, and we can also add on some antibiotics to the patient also.
Anybody using anything else? Anybody following a different protocol?
Interseed can also be used in this.
Although there is no evidence regarding which is a superior modality, most of the infertility specialists and in our practice, we prefer giving hormonal therapy with estradiol valerate, and
Yeah.
these are the cases which require extensive, for at least up to 2 months, they might be given. And also the follow-up of these patients is very important. So you evaluate the endometrium, take help of Doppler to prognosticate. So moving forward, 2 fresh cycles were done for this patient and 1 FET was done. Good embryos were transferred, including blastocysts. She had a biochemical pregnancy in the 2nd cycle. The ET was, however, always, somewhere between 6.5 to 6.9. Only once it reached up to 7.1, and this was the conception cycle. 2 cycles were cancelled in the middle because of less ET. So she's waiting for her next transfer. What can you do in the waiting period to improve her chances?
Platelet-rich plasma therapy.
PRP therapy.
Yes, or the granulosa cell stimulating factor injections. I know there is no proven evidence for it, and use of during the FET cycle when we are preparing the endometrium, we can use sildenafil and other things like arginine sachet for increasing the blood circulation of the endometrium so that the thickness can be increased.
So definitely, the answer I was looking for here was we have already actually talked about this second look hysteroscopy. So these are the cases. The need for secondary look surgery, might be there. And we've already discussed all of this. And yes, adjuvants, although again, the guidelines are still hazy on the role of adjuvants, but we all tend to use it in our practice, especially PRP installation, sildenafil, and GCSF. But however, we need more evidence and more guidelines to corroborated. So second role of second look hysteroscopy, we have already discussed, but when is it? How do you make the decision that this is the patient that we need to take up for second look hysteroscopy?
During the evaluation, when you are giving everything in the endometrium, good quality endometrium, triple line endometrium, we are not able to see it on ultrasound, and we have a repeated cycle cancellation because we are waiting for the endometrium to grow, and this is frustrating both for the treating doctor as well as the couple. So after 2 to 3 cycles, they come with the idea ki ma'am, let's go for the new modality. Everyone is very well read today.
So I think we will just conclude here because the next case is really long. We've already exceeded our time limit. I would just request all my panelists if you would like to make a quick take-home message, if you want to give your comments. We unfortunately could only discuss about the hysteroscopy cases today, but the next is a really long case to take up a lot of time. So I would like to conclude here. So if anybody likes to give a comment based on our discussion today. Or we could have the seniors, Dr. Sunita ma'am, with their valuable inputs. It would be great.
Actually, in the flyer, Parul sir and others' name was mentioned. So I was looking for
Parul sir
his.
could not join in. I know we all have
because I have worked with him.
Sir had
and,
to rush in for an emergency.
Okay, I have worked with him and have joined him in many of the IAG or international conferences. So I know him very well. He is very adept in like surgical things, ranging from ops to gynae to laparoscopy and everything. So I wanted that.
It would have been an absolute treat to listen to Sir, but unfortunately, Dr. Kuldeep and Dr. Parul weren't able to join us today. They had to rush for emergencies. We have Sunita ma'am here. Madam, could you
Yes,
give your
Mansi.
valuable comments?
Yes, Mansi, very well conducted, and it's a really very useful and informative your panel discussion. And I'm very happy that people from our chapter has just interacted with you. Like we are sitting in Delhi, and these girls are doing a very good job here. You know that we are sitting in a very low resource settings, but then these young lads are going to be our bigger heroes in the near future. And thank you so much for a very wonderful panel today.
My pleasure, madam. It is also a pleasure to collaborate. That is why it's a constant effort to bring people from all over India together, share their practices and share their experiences. And that is why we have this last year we had started this special group of endoscopy members called the Endoscopy Squad. So these are usually the young and budding endoscopic surgeons who, contribute towards our SIG. The opportunity of sharing their experiences and organizing and hosting academic events and even like these webinars and all. So it is absolutely our pleasure also to collaborate with Jharkhand Society today. And I would like to thank all of you, all my panelists, Desh Deepak sir, all the senior members, Dr. Sunita madam, Dr. Taruna madam, for joining us and sparing their valuable time. Thank you.
Thank you.
Thank you.
Thank you very much, Dr. Mansi and all the panelists. It was really a very good and interactive session. So many take-home messages for every one of us, and very well explained why hysteroscopy is so much important, especially in long-standing infertility cases and failed IVF and failed IUI cases. Those things which we miss or which we cannot diagnose by ultrasound, like chronic endometritis, Asherman's, So we can find out those causes in hysteroscopy. So it was a very good session, and I think uh, we can conclude the session, and that's it. With this, I just want to thank everyone, our patrons, Dr. Karuna Jha Madam, Dr. Sunita Jha Madam, Secretary, Dr. Rupa Shri Ma'am, our guest speaker, Dr. Desh Deepak Sir, Chairperson, Dr. Vinod Agrawal Sir, Dr. Mansi, our coordinator, and all the panelists. And I will also like to thank our academic partner, Sibella by Intas. So thank you, everyone. And goodbye, I think. Bye-bye.
Mansi, sorry for delay from my side. I just forgotten the time.
No, sir,
Sir,
not at
but
all.
it
It was
was
an
Sorry to all
absolute
the
treat
it
to
was
panelists.
watch
very
all
good.
those
Uh,
interesting cases.
and
Sir,
thank you
Sunita
to share
ma'am,
about the all
Sunita
the
ma'am
beautiful.
rightly said that you were the hero of this session.
अरे नहीं
We
मैडम.
were glued to the screen. Sir,
So
we were glued to the
actually,
screen. So many rare
I'm
anomalies we
doing
were
lots
able
of
to see.
surgery, endoscopic surgery, but still I need a
Yes,
steel nerve to operate on uterine anomalies. They are so confusing, so challenging, and it was, you know, like it was my pleasure as well. It was just delight to watch all your surgeries.
exactly. So
चलो.
many anomalies we watched today. Surgical, matlab, surgeries of those anomalies, not only anomalies.
Yes,
Yes,
madam.
So
sir.
it was
Even
real
surgeries
pleasure,
of
sir.
anomaly, open surgeries are so
Yes,
challenging, and you have
yes.
done like endoscopically so beautifully. Like
Okay,
hats
madam.
off
We
to
will
you,
share
sir.
the non-edited video also in the group if it is possible. Okay.
Yes, sir. Yes,
Okay.
sir.
Yes, sir.
Very
Please,
much
sir.
like required.
That will be our
Most
pleasure.
welcome.
Thank you. Thank you very much, madam. Thank
Thank
you.
you very much. Thank you, sir.
All your
Thank
videos
you
were
so
very,
much,
very
everyone.
very good and self-explanatory. So thank you, all of you, the whole team of IFS Jharkhand chapter. I must thank all of you. And Mansi, you did the moderation so well. It was beautiful. It was really a
Thank
pleasure
you,
to
ma'am.
watch. And I must thank everyone, all of you. You did your job so nicely. Preeti, Soumya, Sunita, everyone, you did your justice with all the things. And I'm very happy to join today. And I'm wishing you all the best for future as well.
Thank you,
Thank you.
ma'am.
Thank you so much, ma'am. We are so fortunate to have you here. Thank you, ma'am.
Support team, please end the program.
Yeah, sure, sir.